everyone. Thank you so much for joining us this evening with PhysiLink. My name is Shrihan. I'm here with Cheyenne, and we're excited to talk with Dr. Catherine Millender today. So for those of you that are new to PhysiLink, if you see my screen right here, PhysiLink is a growing network of physicians that we're hoping to connect with pre-med students in college and high school. And so each month we highlight a physician of the month. This month is Dr. Catherine Millender. We have a bio about them, and then we also have an ongoing Q&A that'll be running throughout the month. And then we also choose a date for once a month, and we'll do a case study and also a Q&A session like the one we're in right now. And at the end of each month, if you go to previous physicians, we'll have a collection of all the doctors and also the Q&A questions that we've asked in the past. And we also do have a resident of the month as well. We had Dr. Lee yesterday, who is a pediatric resident at Brown University. And similarly, we'll have the previous residents as well. And we'll also upload everything to the podcast and our YouTube channel as well. So just to get started, Dr. Catherine Millender is currently a pulmonary care and critical care medicine physician at MUSC. And she is also the medical director for respiratory and critical care services as well. And so she also teaches at the Virginia College of Osteopathic Medicine and serves as the Alumni Association Board and also the Board of High School and Healthcare Professions. Dr. Millender, is there anything else you would like to add in your introduction?
No, thank you so much for the introduction. That's, for my professional career, and then at home, I'm happily married with 2 kids and 2 dogs. So thank you for having me.
Yeah, of course. Thank you so much for taking your time to join us this evening. So I guess just to get started, could you explain a little bit about your specialty and what pulmonary and critical care medicine is?
Sure. So I am a triple boarded physician, so internal medicine, pulmonary medicine, and critical care medicine. And primarily I work as an intensivist. So that means that I am only an ICU doctor. So in general, that means that I take care of patients that are the sickest in the hospital. If they are on life support of any kind, that's generally the patient population that I take care of.
Okay. Could you talk a little bit about sort of what the typical cases are and the caseload and sort of how that works?
Yeah, absolutely. So we'll talk a little bit about that some when we get into the presentation to go through like what a typical day looks like. The bread and butter of patients that we take care of are ones that we call like septic shock, meaning patients who have an infection with very low blood pressure requiring life support medication. Hypoxemic respiratory failure, meaning their oxygen levels are low and they are requiring a ventilator to help breathe for them and get their oxygen levels up. We take care of the ICU I work in is all kinds. So it's not just medical problems. We also take care of trauma patients, neurological patients. So someone who's had a stroke, heart attack patients, heart failure. And then one of the other big things that we see a lot is diabetic ketoacidosis. So patients who have diabetes and then for some reason aren't producing enough insulin to the point where they get abnormalities in their labs, become very sick, and end up in the ICU. So that's kind of our bread and butter that I take care of. And then there's also subspecialties in ICUs across the country.
So with critical care, a lot of people may be wondering sort of what's the difference between that and also emergency medicine. Can you talk a little bit about how the two specialties are a little different?
Yeah, absolutely. So emergency medicine they also see critically ill patients, but typically what an emergency room physician's job is to do is to take care of the patient and stabilize them. And then hand the patient off to me. So some patients coming through the ER can have things as simple as a hangnail or be the sickest of the sick. And that's usually also when they'll call me down and assist with these patients as well in the emergency room.
So do you sort of take care of your patients more long-term than emergency medicine, or is it still pretty much the same one? Okay.
Yes. So typically an emergency room physician shouldn't be seeing a patient for more than a few hours. I take care of patients for days. And hopefully not longer than that. No one wants to be in the ICU for more than a few days, but occasionally it happens.
And sort of going off of that as well, I know emergency medicine is more like shift work. How do the hours work for critical care? How is that different?
So it completely depends on where you work. So for me personally, in the facility where I am, I'm currently the only intensivist. So I work Monday through Friday, and I am available by phone most of the time after that. Generally, some hospitals for intensivists, they'll work 12-hour shifts and they'll work 7 days in a row. So they call it week on, week off scheduling, where they'll work 12-hour shifts Monday through Sunday, and then they get the next 7 days off. And they can either be only on for 12 hours, they can be on for 24 hours. It completely depends. Some models also only have you working, in hourly blocks, a minimum of 6 hours, a maximum of 24 hours. So it completely depends on where you are.
And then how long are your shifts? I know you're saying Monday through Friday, but how many hours each day?
So I am contractually obligated to be in the hospital between 8 a.m. and 5 p.m., but I get phone calls all the time.
So did you sort of have those hours when you came in as well, or did you have to sort of work for a while to get to that level of flexibility? You decide how many hours you choose to work.
So for this hospital, these were the hours that I chose to work because I was building the ICU in the hospital that I'm in. At the previous hospital where I was, it again completely depended on which ICU I was in. It depended on whether I had residents and fellows. So things like that.
Got it. So could you just talk a little bit about also what are some common challenges or problems you encounter in critical care, either with patients or just the field as a whole, on just issues as well?
Sure. That we could probably spend hours talking about. Some of the most challenging things, that we see. Obviously, I take care of patients and their families on the worst days of their lives. So that's probably one of the biggest challenges is just the interaction with people. A lot of the patients that I have also are incapacitated and really can't give me much history or tell me about themselves. So it's really a lot of detective work where we go back and we look and see what other history it is, what more information do we need to gather, why is this happening, what do we need to do about it. So those are some of the biggest things. As with medicine, the ICU is a scarce resource, right? So there's not a lot of me. There's not a lot of ICU rooms. There's not a lot of ventilators. During COVID, we were constantly doing ventilator checks to the point where we even got low on oxygen, to the point where we had difficulty with oxygen. So scarcity of resources is a big thing. And then the community where I work, there's a lot of medical distrust. So in the Deep South, there are always concerns about just physicians and hospitals taking care of patients, that some communities feel as though patients and physicians physicians aren't there to take care of patients. They're just there to line their pockets. And so we do encounter that a lot. Misconceptions and disinformation. We take a lot of time to try to educate and try to overcome those barriers.
Definitely, yeah. One of the things you're saying, I know you're saying that you're really dealing with patients on the worst day of their lives. Have you really learned anything from talking with them, like how to deal with patients, how to help them through that moment?
Usually it's helping the families through it. And so everybody's different, right? And so when I'm taking care of a patient in the ICU and things are metaphorically crashing and burning, there's a time element to it. I don't have the luxury of some physicians who have known their patients for years in the office. I met you 5 minutes ago, and I have to be able to gain your trust in these 5 minutes to tell you, I really am the expert. I really am here to take care of your loved one. Let's open up that shared communication. So that's taken a lot of time over the years, and it's something I still work on, is how to best communicate with patients and their families. So that's a work in progress, I think.
Are there any specific tips or strategies that you've learned from that?
Say one more time. I didn't hear you.
Are there any specific tips or strategies you use when you go to talk to patients?
Seek to understand. So the way I always start a conversation with the patient or with their family is, what is your understanding of what's going on? After I've already, talked about, introduced myself and things like that. But the very first question is, what is your understanding of what's going on? So that lets me know where their starting point is and how much education we need to do, and then go through it. And then the other thing is, what concerns do you have? Is always asking those questions, because families are going to have concerns. Obviously, again, their loved one is very sick. They're very sick. They don't understand what's going on. And I never lie to patients. May not be blunt with the truth. I get the question a lot, am I going to die? I can't guarantee that they're not going to die during this admission. I'm not going to say that to their face, but the thing is we spin it and say, my job is to take care of you, and we're going to do the best that we can with that.
Got it. I think that's a great point. Definitely keeping a patient sort of level with you throughout their entire process. Nice.
It's an
One of the
ethical
things
thing
is,
too.
sorry,
That way they know what I know.
got it. One of the things you also mentioned was it can be hard to get the patient's history when they're incapacitated or not able to tell you. You're saying that the patients first go through the ER, right? The emergency medicine physician see them first.
Sometimes there are on occasions I'll get direct admissions. But
Mhm.
yes, the emergency room physicians are probably 99% of the times the one that see the patient first.
Did you communicate with them as well to get the patient history from ER, any data that they collected from them?
Yes, absolutely. So always talk with the ER physician and discuss what their findings were, because maybe they got a report from the EMTs prior to the patient coming in, or maybe there was a family member that came in that was, also needed medical treatment, and I can't talk with them, things like that. So usually, well, not usually, we always get corroborating, stories from everyone. But again, if the patient is incapacitated in the field, prior to coming into the hospital, our histories may still be even limited from there. Sometimes patients come in without IDs, a bystander finds them and calls 911 and then leaves the scene, and we don't know who this patient is. They were found down. They can't tell us anything. So we do the best we can.
How do you sort of work around that? You really can't get any information from them for history.
Treat them the best we can, do
Yeah.
support the best we can. And we also we have case management and social workers that also work on finding the patient's identity. Usually over time, there will be a family member that comes forward looking for a patient with this description, and then we can find them. Or if they were found in a location, at home, at their address, we can send the police back out to find out who resides in that address.
All right, thank you. And then last thing as well, you talking sort of about how intensive care varies for the communities. The Orangeburg community is definitely very different, but have you also worked in any other communities, and how have you seen intensive care sort of change across all of those?
Yeah, absolutely. So I work prior to being in Orangeburg, I worked in Columbia. So I worked at the major hospital in Columbia here, and we took care of different patients there because there's different services at a coronary care hospital, like the hospital here is. Um, so it's but every single ICU is different. So I worked at 3 different hospitals now, and each one is unique in its patient population and the way that things are managed, how things are done. So it's still, there's not really a standardization for every single ICU or every single hospital.
Are there any certain cases that you see more common out or more prevalent at one location than the other?
Well, septic shock is the bread and butter for every single intensivist that there is. Obviously, if you're working in a neurosurgical ICU, you're going to see solely neurological cases. If you're only working in a cardiovascular ICU, you're going to mostly only see, open heart surgery patients, or ECMO patients, which is extracorporeal membranous oxygenation, where patients are put on a heart-lung machine. Um, Pediatrics, you're going to take care of kids. Obviously, all of this is I only treat age 16 and up, so I can't talk anything to peds. So sorry for anyone that's interested in pediatrics. I couldn't help you with that. So it completely depends on what the specialty of the ICU is. If it's a surgical ICU, a trauma ICU, things like that.
Great, thank you. And then one more question in the chat as well. One of the patients are asking, or one of the students are asking, how do you navigate a case where the patient and or family clearly doesn't trust you?
Yeah, that one's really hard. So if, we try to gain trust, and that's again where you open that communication pool and say, what are your concerns? And usually there's some sort of something, either a cultural something that is underlying, or, they heard a rumor about some illness or, something during COVID that I saw all the time was, I don't believe you, COVID's not real, or you're just using me as a guinea pig. And so usually we just try to sit and educate and say, like, tell me what your concerns are about that. These are the medications. This is peer reviewed, and just really sit down. And there are occasions where you're just not going to bridge that gap, and you still rise above and you still treat the patient and do the best you can. Occasionally, there's another physician that you can reassign the patient to if there really is that big gap there of mistrust. But usually it's a mistrust of the system and not necessarily of one person.
Okay, so your goal mainly is to sort of get the patient to open up to you and sort of be clear about what they have.
Really, open up, try to understand what their reservations are. I've lived a very different life than a lot of these patients have. I've lived a different life than you have. That's just, everybody's life is unique and individual, and we all bring our own biases to things. And so there might be something that they have experienced in their life that I would never understand unless they, told me these are my concerns about it.
All right, well, if any of the students have any questions, well, feel free to drop that in the chat. You can also now, I guess, move on to your teaching experience. Can you talk a little bit about your role teaching and sort of what you do in that role?
Sure. So right now I teach fourth year medical students for the Virginia College of Osteopathic Medicine. So the students will rotate for 4 weeks with me, and basically they see and do everything that I do. They get assigned patients. We go over cases. We do certain teaching topics every day. And then if there's procedures, I'll teach them about the procedure. So usually it's a see one, do one, teach one, but we don't have too many other people to teach. So I make sure that they're in there seeing and doing the procedures and bedside with the patients for everything. My goal is to have them be good doctors, and the more that they can see earlier and the more they can understand earlier, the more they'll be equipped and ready to go when they graduate medical school.
I know a lot of people don't know too much about osteopathic medicine. Can you talk a little bit about the differences between a DO versus an MD?
Sure. So I'm an MD. And so to be quite clear with you, I don't teach anything differently between a DO and an MD. So the students that I have are all DOs. They are all osteopathic medicine track physicians or students to become DO physicians. But the training that I give them is the exact same that I would give medical MD students. The only difference that we see for our students through VCOM is that they will have something called OMM, where they go and use manipulation techniques in a class. But I don't do those. I don't teach them. I don't know anything about them. So I think that's the biggest difference. But the two tracks are becoming very much the same over time.
Do you see any specific students as you watch students from the DO school? Do you see anything that they do differently? I know you're saying the technique they use, but pretty much the same.
Nope, they are very much the same.
And then also, how did you get into teaching, and sort of why did you also decide to begin teaching?
I loved it. So when I was working at the hospital here in Columbia, I would teach medical students, residents, fellows, and that was something really important. So when I started my new job with NUSC 5.5 years ago, they approached me and asked if I would be willing to teach students. And I said, yeah, sure.
Is there anything specific you really learned from that experience about students or how they learn?
Every single student is different. And so teaching styles for them, I usually sit down at the beginning of the rotation. I ask, how do they learn best? I always hated being lectured to. Like someone standing up at the front of the classroom, I'm not going to learn that well. I have to see it. I have to do it. I have to be in it. And so that generally is the consensus for adult learners of how they like to learn, is to actually experience and be in it and learn on patients. Mostly it's that the students can teach me so much. So we had a case today, and the student said, I think this is pneumonia. And I said, I don't think it is, but let's find out. And the student was right. It's pneumonia. And so we, talked it through. And so they keep me on my toes for sure. I have learned more from them than I think I could ever give back.
You're saying a lot of students like being hands-on. Are there any other specific learning strategies you've seen being useful?
Some students like to write down things and then read those
Mhm.
notes. I sometimes will have them prepare small presentations. And when I say small, I mean, I'm talking about like 5 minutes. Nobody's got time in the day to be doing these, hour-long presentations while we're trying to take care of critically ill patients. And then I also will have them teach the nurses. Our nursing staff is very used to having these kinds of lectures, if you will, from the students. And so I feel as though if you are a true master of something, you're able to teach it to somebody else. And so I think that really helps them solidify and learn and be able to help others too.
Thank you. I guess we can now move on to a little bit about your role on the Alumni Association Board for UC School of Medicine, and also I think you said the high school healthcare professions as well. Can you
Yeah.
talk a little bit about what that is and what that entails?
Yeah, sure. So, the Alumni Association for the University of South Carolina School of Medicine. So, basically, what we do is work on alumni engagement, activities for the students, community engagement, fundraising, things like that. So, a lot of it is how can we get more involvement from the alumni, from the students at the School of Medicine. So, that's part of that. I think I've been doing that for 6 months now, and then the board for the high school, the school for professionals, healthcare professionals. That is a magnet school in Orangeburg, actually, that feeds in students. And the goal of that school is to either have people enroll, enlist, or employ. So they enroll into some sort of college or technical college after graduation, enlist in the military, or become employed. We know that in the area that school is in, there's a very large number of students that either drop out of high school and don't work, don't get their GED, anything like that, or they graduate and then again don't work, and causes issues in the community. So that's really the goal: is how can we best serve those students?
So do you work for both of these programs? Do you work directly with the students, or or is
I
it
do.
mainly just actually planning events then?
So it's mostly it's the board as planning events and community involvement for the School of Medicine Alumni Association Board, and then the board for the high school professionals. That one is kind of guiding how the school is run, since it's a magnet.
All right. Well, that's all the questions I have about the teaching side. We did get one more question in the chat.
Yeah.
They said, I would assume that caring for critically ill patients can be both mentally and physically demanding, but how did you manage those challenges while also maintaining your effectiveness?
Yes. So absolutely great point. So work-life balance and having good coping skills. So one of the other things that I'm working on doing is being a peer support advocate. So basically, for other employees that are going through a hard time, I'm there for them to come and talk to. But mostly through that whole process is making sure that I keep myself sane first, right? You can't pour from an empty cup. So I have to make sure that I take care of myself so that way I can better take care of others. So I make sure I have a workout regimen. I get up in the morning, I work out, go to work. There are some days where I am physically exhausted by the end of the day and I come home and crawl into bed. But pretty much every single night, I cook dinner. We sit down at the table with my family. Family time is 100% so important because my family will always be here. My job, doesn't matter that much. Like, yes, we do great things, whatever, but my family is who I'm going to come home to at the end of the day. So that's the biggest thing, is making sure that I am taken care of first and then take care of others. So it's a little bit selfish, but it's also, again, you can't pour from an empty cup.
Are there any specific strategies or time management techniques you use to manage to fit in the things that you want to do for fun with also your career?
Have Having two 11-year-old boys
Yeah.
is I have I have no free time. And I'm actually getting my master's right now too. So No, I don't have any good tips on time management other than get 8 hours of sleep every night and 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 make things work as you can. But that's pretty much the biggest one.
And then another question in chat as well. Previous physicians have mentioned systematic changes aimed at preventing burnout and exhaustion. Have you observed any initiatives at Orangeburg or also how these challenges are addressed over time?
Yes, absolutely, 100%. So we have data that comes out every single year. Just a backstory on this is critical care medicine has one of the highest levels of burnout of every subspecialist or specialist in medicine. So preventing burnout is huge. And so again, that goes back to the work-life balance. I make sure that when I'm home, I'm home. I have made it a rule. I don't pull up charts when I'm at home. The nurses, if they need to call me, absolutely, please do. But they've recognized over the years that, if you're going to call me at 2 a.m., it's got to be a literal life and death, not just a chat. And again, making sure that I take care of myself first. So again, you can't pour from an empty cup. So that's the biggest thing. It's just having good boundaries about work life and taking care of yourself.
Speaking of getting called at 2 a.m., are you also on call ever for intensive care or no, not usually?
So it completely depends on which practice you're in. So sometimes people will be on, they don't have to be in person, but they have to be available by phone. I am available by phone usually until 9 p.m. every night. And then we have hospitalists that will cover the ICU for us at night. And we also have a tele ICU program. So that way, if someone is becoming critically ill, there's an intensivist via the cameras in the room that can look in. So it depends. During COVID, I was on 24/7, but now it's thankfully we're not going back to that yet, I hope.
Well, that's sort of all the questions I have in terms of your career. I guess now we can just move on to before the case study. The advice you have for current pre-med students, whether in high school or undergrad, could be either medical advice or just non-medical advice. It could be anything.
Oh man. Some days I still wonder if I haven't gotten everything all figured out. So, for medical school, it is you're dedicating your life to this career, and your 20s and part of your 30s will be completely dedicated to learning this. And if it's the right choice for you, it is 100% worth it. And if you're not willing to give up your 20s and your early 30s to a hospital and other people, then maybe that's not right for you. But for me, it was 100% the right choice. I love everything that I do. The biggest advice that I've given to everybody pretty much every single day, and I still abide by this, is medicine is a constant learning process. You will always need to continue to learn. And so that's the biggest thing, is always have an open mind and absorb everything that you can, both, from a textbook, from life, from other people, whatever.
Going sort of off of that as well, any techniques you have for students to manage their time or balance their mental health or using the activities that you think would be most meaningful for them?
So again, every single person is different. And so, some of my outlets are, I'm going to talk to friends. A lot of the times I'll, call my husband on the way home from work, listen to a podcast, call my mom and complain about something. Morning times I'll get up and I do my workout. So that way I kind of feel up and ready to go for the day. I'm really big into, nutrition and making sure that we're eating appropriate things. I try not to do processed foods, but for some people it's, you know what, I need a chocolate sweet treat this afternoon because it's been a bad day and that's what I want. If that's what you need, go for it. If you prefer to come home and sit on the sofa and watch whatever newest reality TV show is, and that's how your brain shuts off and you can recharge, great. If you like to go out with people, I'm very much an introvert. I want to come home and I want to be with my dogs and and do nothing. But some people are extroverts and that's how they, fill their cup, is to go out and spend time with friends. And if that's the case, do it. As far as time management, it is really hard to balance your time in medical school, and it's always constantly learning. And so it's make sure you know access to your resources, so you're not searching around and trying to get information from places about topics or whatever, kind of wasting your time. Ask other people what are good resources. A lot of the times I provide a book for my medical students when they're coming and rounding with me, so that way they know all the topics I'm going to teach. And if they want to read more about it, they can do that in that book. And then we have other websites and things that they can use. So finding good resources, whether it be people, book, website, whatever, is going to be really key.
Yeah, definitely. I think it's really important to have people to sort of find their own things, see what works best for them.
For sure.
And I know you work mainly with medical students, like for the 4th year, but from your experience seeing them, seeing how they behave, is there anything that you think students in general should not really stress over?
That's a really good question. Not stress over. Well, once you made it into medical school, once they've gotten to rotations with me, they've pretty much gone through everything. They've gone over most of the hard stuff. I can't think of anything right now. I'll have to think on that one. I'm not sure. As a type A person, I stress over everything. So
Okay. There's one more question in chat.
Yeah.
Considering the specialty that you work in, how do you go about breaking bad news to patients and or their families? I know you're saying it is difficult to get them to trust you, but yeah.
Yeah, absolutely. So, I mean, I probably break bad news on a daily basis, probably sometimes multiple times a day. The things that I've always been taught, and again, this is, I think about how would I want this told to me? So I'm a tall person, and with my work shoes on, I'm pushing 6 feet. So I always sit down. The patients are in bed, they're laying down. So I always sit down next to them. I, again, start with, tell me what your understanding is of things that are going on, either with the patient or the family members. And then I tell them the facts as they are. I, again, don't try to sugarcoat things. We never use euphemisms, and because they can be misconstrued as something, or I'm not going to be harsh about things, but I'm going to tell it like it is. If I've done a biopsy on someone and it comes back as a cancer, I'm going to sit down, ask them what they understand about it, tell them I'm concerned about this mass that we took a biopsy of, and it did come back from pathology as having cancer. I know that's a lot to take in right now. What questions do you have? And then you sit back and be quiet and let them process it. Let them ask their questions, and then you can go on and talk about other things. So that's usually the give them time and hold that safe place for them while they absorb it.
One of the things you're saying is definitely not to lie to the patient, but also, I guess you don't want to tell them all the details. How do you decide between what to tell them and what not to allow them to fully understand everything?
Yeah, a great question. So that's when you go back to tell me what you understand about what's going on. So some people, you can tell just by the words they use, being in a hospital around doctors is incredibly overwhelming. But if I'm talking to another doctor or another nurse and they're going to say, list off all these things, I can be much more technical and give them the details. Sometimes over a few days, and I've gotten rapport with family, I know that they're going to ask what the patient's white blood cell count is. So I'm going to lead with great news. Today, the white blood cell count is down to 11.2. So the antibiotics really seem to be working. So that's kind of one of those things that you feel out how they go. And sometimes, patients want more details. They want less details. You kind of have to feel it out as you go.
Yeah, all right, one more question.
So I love this question. I'm actually going to talk about that in my presentation. So I've got pictures and stuff like that. So.
All right. Well, that's all the questions.
Healthcare is a team. Sorry, healthcare is a team. So I can't do my job without everybody else that I work with. So.
All right, well, that's all the questions I have for you. We can just wait, I guess, a few seconds If anyone has any other questions, please put it up in the chat or just unmute your mic if you can't do that as well. And then I guess in a little bit, we can just move on to the case study.
Sounds good. And we can also do questions at the end too. I don't mind.
Yeah. All right, then yeah, just it's up to you now. Feel free to get started whenever you feel.
Okay, I'll go ahead and start sharing my screen then. Slowly. My computer is slow today.
Yeah, no worries.
All right. So I've got my slides up here. And again, is my internet connection good enough that y'all can see my slides?
Yeah, we can see your slides.
Okay, perfect. So what we're going to talk about a little bit today is we're going to have a case study, but we're also going to weave into what a typical day in the ICU is and really how we approach these patients. So when someone first walks into the ICU and they see something like this with an intubated patient, multiple different lines and drips and a monitor that's beeping and this other machine in the corner, a lot of people go, oh my God, what is this train wreck? What do I do? And so some people shut out, run away, shut themselves out and say, I don't want to be in the ICU. This is too much. It's too overwhelming. The gist of it is air goes in and out, blood goes round and round. And if it doesn't, we have a whole team of people to help you. So these are some of the people that I worked very, very closely with during COVID at my hospital. And so who are some of the people that we work with? So every single day on rounds, I do what we call multidisciplinary rounds. So at 9 a.m., I get together, me, the patient's nurse, usually the charge nurse for the unit, our respiratory therapist, we have a critical care pharmacist, case manager, and then we also have a dietitian that rounds on all of our patients. Usually immediately after rounds, I'll talk with our physical therapist, occupational therapist, speech therapist, and then obviously other consultant physicians. Again, I can't do everything all at one time, so there's numerous other physicians that I'll talk to. Also, the other people that I deal with on a daily basis, we have our x-ray technicians, our specialized nursing, so our cardiac cath lab, our dialysis nurses, OR nurses, endoscopy, we have phlebotomists, lab techs, and then surgical processing specialists. So pretty much anything you can think of, and I'm sure I've left something off of this list, they're people that I work with and interact with on a daily basis. So going back to something we talked a little bit about earlier, what are some of the most common illnesses we see? Respiratory failure is a big one. So someone who needs to have a breathing tube put in and put on life support or the ventilator, that's what we take care of. Septic shock, meaning that we have an infection that's caused the patient's blood pressure to go very low and they're requiring life support medications. Congestive heart failure, sometimes we have to put them on IV medications that help the heart beat better. Diabetic ketoacidosis, which is that illness we talked about earlier, particularly in type 1 diabetics, where if they're missing their insulin or they get an illness, they can have significant elevations in their blood sugar levels and also develop what we call acidosis, where their body isn't able to utilize the glucose, the sugar that they have. We unfortunately see a lot of cardiac arrest patients. So these are patients whose heart stops beating and they require CPR, chest compressions, breathing tube, things like that. We also see heart attacks, so patients that have come in with a blockage in one of their coronary arteries, and they have to go to the cath lab, and then we admit them to the ICU afterwards, and then brain injury. So this can be anything from, a car wreck, head bleed, a stroke where there is a blood clot to the brain. We have seizures, so something called status epilepticus, meningitis, infections like that. So those are the most common things that we see. And again, if you're going into a subspecialty ICU, you're going to see things in the subspecialty ICU. So we're going to go through a case, and I'll be honest with you. So sometimes, again, when you're going into an ICU, seeing all of these things can be so overwhelming. So we're going to break it down and not necessarily talk so much about the patient, but how we approach these patients. So I had a patient come in. She's a 60-year-old woman. She's got a past medical history significant for osteoporosis, which means that she had demineralization of her bones. She has chronic pain. She had been on chronic opiates because she had fractures related to the osteoporosis. She came into the emergency room with shortness of breath. Her past medical history, she's a non-smoker. She didn't drink alcohol, no history of any illicit drugs. She takes tapentadol, which is a long-acting mu-opiate medication. So something that's kind of similar to morphine, but not quite the same receptors. She had previous spinal fusion, but otherwise was a relatively healthy lady. The ER physician, when they gave me a call, noted that she had low oxygen levels, or what we call hypoxemia. She had an elevated heart rate and was actually in an abnormal rhythm called atrial fibrillation with a rapid ventricular rate, which meant her heart rate was much higher than around 120. When the labs came back, we noted that she had an elevated white blood cell count at 13,000, which indicated that there is some sort of inflammation or infection, which is why the white blood cells had been elevated. And then there's something called bandemia. So she had 46% bands, which is incredibly high, which means that there's a lot of immature white blood cells that are being detected in the blood, which means the body is really ramping up some sort of immune response. We did a renal function panel, and it did show that she had an elevated creatinine, which is a marker that we use to evaluate for kidney function. So she did have acute renal failure. We did do an RSV swab, and it came back positive. And so in the ER, blood cultures were drawn. So again, on physical exam, her blood pressure was marginal. She had a blood pressure of 92/40. Her heart rate was elevated at 142. Respiratory rate was elevated at 24 breaths per minute. Her oxygen saturation was 92% on 100% non-rebreather, which means that we had a small mask on her face that was giving her 100% oxygen. Normally, you and I breathe 21%, and the majority of people are going to have oxygen saturations on room air greater than like 96%. She had a fever of 100.8 degrees. She was awake. She could talk to me, but she was definitely having some moderate distress. We're going to skip down some on this, but basically her head exam was normal. Her eyes were normal. Her oral mucosa was normal. Her trachea was in the middle, meaning that there wasn't some sort of major mass that was pushing either in her lungs or in the mediastinum around her heart, pushing her trachea around. And she had no jugular venous distension, would be something we would be concerned about with a heart issue or something like that. She had an elevated heart rate, so tachycardia into the 130s by the time I saw her. Her lungs had crackles on both bases, indicating that there was some sort of fluid in them. Her abdomen was soft. Her extremities were normal. She was pretty weak. And then this is her chest x-ray that we see here on the right side is abnormal, indicating that she has these infiltrates on both sides of her lungs towards the bases.
Dr. Millender, just really quickly.
Yeah.
I don't think we can see you clicking through the slide. We're still staring at the title slide.
Dear. I'm sorry. Again, computer issues. Yeah. Okay. Can you see this picture or no?
Yes, we can see that now.
Okay. Maybe if I just click through like this and then.
Yeah, that should be totally fine.
Okay. All right. Sorry about that, guys. You should have yelled at me earlier. Okay. So again, we'll just jump through the slides that we skip. When someone walks into an ICU and you see this, everyone freaks out and says, oh my gosh, this is a train wreck. Air goes in and out. Blood goes round and round. And if it doesn't, these are the people that you meet. We talked about the people that we worked with. The most common illnesses you can see here on this slide. Talked about our case presentation. And then this is our patient's chest x-ray here, where you can see on both sides towards the bases, we have this infiltrate. All right. Y'all are seeing it okay now?
Yes, we can see it okay. Can you talk a little bit more about the chest scan and sort of what specifically you're looking for?
Yeah, absolutely. So the projection on this is not stellar, but we can see that this is the patient's heart border here. So she has a normal heart border. We can see that her windpipe or her trachea comes down here at the carina where it bifurcates or splits off right here. So this is normal. Up here, this is what normal lungs should look like. And it should extend all the way down to around here. And you can see here all of this white fluffy in here. This is fluid or inflammation. So it can be pneumonia. You can have something called pulmonary edema. But in her case, this is pneumonia. And so you can see this on both sides where it has this really white fluffy look, when in reality, it should have more of this darker look up here. And you can see her mask is on here. So this is what the tubing is. And then we have all these leads that we've placed on her for cardiac monitoring. So how do we approach these patients? You don't want to get lost in all of the details, but all the details are important. So when we have someone who comes into the ICU, especially if they're on life support, we, as the medical team, we control everything. I determine how much oxygen they breathe, how many times they breathe. I determine what their heart rate is, what their blood pressure is, how much they eat, drink, poop, and pee. So it's really important for us to know all the details. So for me, I start from top to bottom. So I usually start with a neurological exam. So every single patient has a neurological exam, even if they're what we call intubated with a breathing tube in and they're sedated. We always make sure that our patients have adequate pain control. So if they are intubated or on life support, we're going to make sure that they have a medication called fentanyl or ketamine, and we usually do this continuously. We also have anxiety control, so we can use propofol or dexmedetomidine. These are continuous infusions. And then something else that's really important to maintain good sleep-wake cycles or their circadian rhythm is we'll also start some patients on melatonin. So that way, even though they're sedated, they're not truly asleep. So maintaining good sleep cycles really helps patient outcomes. So here in this picture, this is what we call anisocoria. So this pupil is larger than this one. That can be normal in some people, but generally when I see it in the ICU, that's a problem. So cardiac. This is a big one that we look at, obviously. So we want to know what's the patient's blood pressure and are they on what we call vasoactive medicines? Meaning, do I have them on medications through their IV to help keep their heart beating and keep their blood pressure up? Or do I have them on a medication through their IV that's helping lower their heart rate, lower their blood pressure? Well, I want to know what rhythm they're in. Is it a tachycardia? Is it a bradycardia? Is it atrial fibrillation, like what we see on this strip right down here, which is an abnormal rhythm? We can also do a bedside ultrasound and we can take a look at their heart and see how it's pumping. So this is obviously a still picture. It's not the movement, but we would be able to see that. Left ventricle, left atrium, and right ventricle. And then we can also look at what their cardiac function is here. And then this down here is an ECMO machine. So some people think of heart-lung bypass machines as being really big, but these are actually slightly bigger than a suitcase. And they pump through 6 liters of blood from the patient per minute. So it's a lot of blood moving through that machine. So pulmonary status, is your patient mechanically ventilated? We need to know what the sedation or what the settings of your ventilator are. Is the patient tolerating it? Are we ready to take the breathing tube out? Have you looked at their chest x-ray? Are their oxygen saturations good enough? Have we determined what their carbon dioxide levels are? Is it good enough? We ventilate these patients, and so we want to make sure that they're breathing off enough CO2. This is what a lot of our ventilators look like right here. These are, you can see a hospital bed right here, so they're not huge. And then this is the tubing that connects to the patient. And then if we do what we call an endotracheal intubation, this is how we do it. So we take a laryngoscope, we put it into the patient's mouth, and then we slide the tube down into the patient's lung and inflate this balloon so that way the air only goes in and out through the tube. And then we attach the tube here to our ventilator. This is either the point where people check out and just go, bro, why am I still here? This lady talks too much. Or they get overwhelmed and say, I just need a nap. So we'll take a little step back here for a second, take a deep breath. This is Stella when she was a puppy. This is the love of my life. And this is Luna, my other puppy, who's much bigger than Stella, also the love of my life. And they are the reason why I have sanity. So I'll pause for 2 seconds and see if anyone has any questions about anything that we've done so far. And I don't have the chat up, so I'm not looking at that. But if everyone's good, we'll keep going. All right. So next for our GI, so gastrointestinal, we want to make sure that all of our patients are fed. Okay, so here what we're looking at in this picture is we can put a tube into someone's nose, down into their stomach, and we can feed them that way. So this shows a syringe, but usually what we do is hook it up to a pump. We also want to make sure that we evaluate our patients if they have any sort of malnutrition. So some patients, particularly cancer patients or those with AIDS, they become very malnourished over time. And so sometimes when we start doing these feeds for these patients, they can actually develop refeeding syndrome and get even sicker. So we have to be really careful. We also want to know if these patients have had any surgical intervention. So did the patient come in because they had a bowel obstruction and had to have part of that bowel taken out? We need to know what's going on. We need to know, is the patient bleeding in their stomach or somewhere along into their small intestines or their large intestine. And then we also want to monitor their liver function. Liver is incredibly important when it comes to metabolism and the clotting cascade. So how well does someone clot and prevent them from bleeding? So kidney, renal, we want to monitor electrolytes every day. We monitor volume status, and then we evaluate whether the patient needs dialysis or not. A lot of the times, unfortunately, when patients come in and they're put on life support, when their blood pressure goes very low, the kidney is a weak organ, it gets injured and it's not able to regulate electrolytes or fluid. And so then we have to place our patients on dialysis. So these are two different types of dialysis machines that we can use in the ICU. So we can either do continuous dialysis called CRRT or continuous renal replacement therapy, or we can do intermittent dialysis where someone's on dialysis like they normally would as an outpatient for a few hours. And then we want to check endocrine. So knowing what someone's blood sugar is very important. We have really good literature that shows that someone's blood sugar is really high or really low affects their outcomes. They're more likely to die if they have really low blood sugars or really high blood sugars. And so obviously we want to avoid that. So we do tight glycemic control for these patients where we check blood sugars, and the goal is for it to be between 140 and 180 on their finger sticks. We also evaluate patients for adrenal insufficiency. So if they're on chronic steroids as an outpatient, and then now they've gotten sick, we need to make sure that they're continued on higher dose steroids called stress dose steroids while they're inpatient. And then we also wanted to monitor thyroid function. If a patient is hypothyroid, it's really important to continue their home medicines. If they come in with a thyroid storm because they have hyperthyroid, we need to treat that as well. So these are important things to keep in the back of our mind. Infectious disease. Again, this is going to be the bread and butter of what I take care of. So a lot of the times patients come in infected. And so we want to know, what kind of infection do they have? Is it bacterial? Is it viral? Is it fungal? Sometimes we get parasitic infections. I do not enjoy those. We want to see what their temperature range is. Sometimes patients come in with very low temperatures where they're 85 degrees, and that can mean that they have an infection. Sometimes they're high. That's the most common one that we see, is someone has a fever. We want to know what their white blood cell count is so we can track that over time to see if we're getting control of the infection. And if the white blood cell count is low, say in a cancer patient or someone who has AIDS, we also need to know, because that is going to tell us what kind of antibiotics we should be using. We want to know where the infection is. Most common is going to be lungs, blood, skin, urine. But we can also have in the GI tract, we can have meningitis, we can have it elsewhere. So we need to do the workup to figure out not only what we're treating, but where it is, so we can figure that out. And we do that with culture data. And then for every single patient, we need to figure out what the right antibiotics are, what the appropriate dose is, and what the appropriate duration is. So every single patient that has an infection or suspected infection, this is what we look at. And then nutrition. I already talked about nutrition is really important to me. And then it's also really important to our patients. We do not ever want to starve our patients. Even if they're on life support, they can still get food. Okay. So we've talked about with patients, if they have a breathing tube in, we can put a tube in their nose or in their mouth down into their stomach and start tube feeds that way. And permanently, if families would like, we can also surgically place a feeding tube called a gastrostomy tube. If patients have had some sort of bowel surgery where they have not yet had, say, 2 parts of their colon reattached, it's okay for them not to eat, meaning nothing by mouth or NPO, for about a week. After that, we need to consider what we call total parenteral nutrition, parenteral, which is what we do with IV nutrition. It's not ideal. We want to use the gut when we can, but obviously for some patients, we have to use TPN or total parenteral nutrition. Just as a note, I get this a lot of times, dextrose and IV fluids are not considered nutrition. They are medications and should not be misconstrued as such. So back to our patient, we're going to highlight, she has a low blood pressure, a high heart rate, high respiratory rate. She has low oxygen levels, on as much oxygen as we can give her before we put her on life support. She has a fever. She's in moderate distress. Her heart rate is elevated. She's got abnormal lung exam, and she's very weak. So what do we do for her? the follow-up on this patient is we did put a breathing tube in, so she got intubated. She was placed on pressors, which are medications to help keep the heart beating and keep the blood pressure up. And the medication we chose was norepinephrine. She was sedated with fentanyl and propofol. We did diagnose her with acute hypoxemic respiratory failure, septic shock, and the septic shock was because she actually came back positive with her sputum culture, so culture from her lungs, and blood cultures that had Streptococcus pneumoniae, which is the most common bacteria that causes pneumonia for patients, but she had managed to get it into her bloodstream. So we did target antibiotics for this. The patient did progress to something that we call acute respiratory distress syndrome. So we add medications called paralytics. So we heavily sedate the patients and paralyze them. And then we can also, instead of laying them on their back, we can lay them on their stomachs to help improve their lung function. And then, as with everybody else, we placed an NG tube to get nutrition and medications, monitored her kidney function. Her kidneys did recover. And then obviously engaged in multiple family discussions because this patient was very sick. She came in quite well prior to coming into the hospital. She'd been quite normal, and now she's very, very sick. So, welcome to the ICU. I hope that no one is intimidated by it. And please let me know what questions you have. Again, this is Stella, all grown up, and this is Luna recently making faces because I told her to stop digging in the yard. So I'm going to stop sharing and see what questions y'all have.
Well, thank you so much for going to the presentation. I know I learned a ton. I hope the students did as well. We had 2 questions in the chat asked during that. One of them was, do you encounter any issues with intubation or endotracheal tubes?
Yeah, absolutely. So when we initially placed the breathing tubes, because what we call laryngoscope, the devices we place in the mouth, the most common injuries we see are lacerations to the lips or the tongue, so we can cause bleeding. Sometimes the lip can get pinched between the teeth and what we call the blade when we put it in. It's just a flat that's not sharp. But the patients will bite their lip inadvertently. There is always a risk of losing teeth. And then obviously with intubation, we can't leave the tube in forever because there are complications from it. So the most common complications, you can get a ventilator-associated pneumonia. So infection is a big one. Damage to structures, you can get breakdown of the mouth where we secure the endotracheal tube. There's tape that goes right here, and you can get breakdown from that. We can also get breakdown into the mouth and back into the oropharynx, or the back of the mouth. And then we can also have something called tracheal stenosis, which is where the balloon that I showed you guys that's on the tip of that endotracheal tube, it can cause damage to the windpipe, and then the damage causes it to narrow down. There is also an incredibly rare occurrence where there can be a hole that forms between the windpipe and the esophagus, which is our swallowing tube, which is directly behind it. So tracheoesophageal fistula is also something that we watch for.
Thank you. One of the other questions was, what does the sedation help with?
Yeah, absolutely. So I'm sure everybody here has had a COVID swab at some point in their life. And we're not talking about the newest ones where they just swab the front of your nose. We're talking about shoving it back as far as you can until you think that you're getting a brain biopsy. And imagine how uncomfortable that swab is. Now, imagine I have that swab in your nose and it's staying there and it doesn't come out, and I have one in your mouth. That's incredibly painful. And so a lot of the times patients inadvertently try to go grab at the tubes because I don't want it. They're confused. They don't know what's going on. So the sedation is to help with anxiety, and it's to help from feeling pain. So we give pain medication and sedation. So that way they're not in distress because of the equipment that we're using.
Well, I think that should be it. We can just stay on the line. If anyone else has any more questions, feel free to type more in the chat or just unmute. Thank you again so much for your time this evening.
Absolutely. Thank you so much again for having me.
Sure.
Yeah. Okay. So, with this interdisciplinary approach in this case, and I'm sure in many others, what does the training and residency experience look like? So, I can't really talk too much about other people's training. But so, training for me, I mean, I did undergrad for 4 years, I did medical school for 4 years. I was an internal medicine resident for 3 years, and then I did pulmonary medicine for 2 years, and then critical care medicine training for another year. And after each one of those, you have to take boards for each of those. Residency, I mean, it's not as bad as it was back when people actually lived at the hospital. But you you live at the hospital essentially. The hospital owns you, work owns you. And let's see. It's a long road. You bury yourself in it. I'm not really sure when you mentioned the interdisciplinary approach. What other aspects do you have? Questions do you have about that? Is that the common path for residency? If you want to do critical care, yes. So residency is the time after medical school where you go and you determine what kind of doctor you want to be. So you can have family medicine, internal medicine, psychiatry, neurosurgery, general surgery, dermatology, ophthalmology. It completely depends on what kind of doctor, what field you want to go into. But yes, for critical care, there's really three paths for critical care. One is you do internal medicine, pulmonary medicine, and then critical care. Some people decide to do internal medicine and go on and just do critical care. And then you can also do emergency medicine and critical care from there. And I forgot one more. You can do anesthesia and then critical care. It's just that one's kind of falling by the wayside some.
Were there any other subspecialties that you were considering when you were deciding to go into critical care?
I thought about doing interventional pulmonology, but I was really more interested in the critical care aspect. You know, when I was in medical school, I thought that I wanted to do surgery, and I loved it. And I mean, I still get to do minor procedures and things like that. But I hated the lifestyle. I actually remember I shadowed a surgeon. It was around Christmas time. And so I was talking to her about, oh, did you get your Christmas decorations up? And she said, no, I don't have time for that. I paid someone to do that. I'm not going to be home for Christmas. And I was like, ooh, I don't think this is the lifestyle that I want. I want to make sure that I'm there for family because that's really important to me. So that was where I started veering away from surgery.
Can you talk a little bit about interventional pulmonology? I'm sure that's not very common specialty as well.
Yeah, it's not very common. So in the gist of interventional pulmonology is they do procedures, they do minor surgeries in the airway, using equipment to biopsy the lungs, put stents into the lungs. You can target certain areas, lymph node biopsies inside the airway, things like that. And so really it's a lot of procedures. And it's a lot of like follow up from that.
All right, well, thank you. I guess that's all the questions for now. We can stay on the call for a few more minutes if anyone else wants to stay back or type in the chat. But yeah, thank you everyone so much for attending. We'll be posting on our newsletter soon about the upcoming webinars as well. But thank you for joining us this evening.
Thank you so much. I'll hang tight for a little bit. Yeah, so fellowships for critical care. So critical care is in itself a fellowship. Subspecializing further from critical care, like medical critical care, I don't know. Oh yeah, no. So there is, you can do neurocritical care. So that is a new subspecialty you can do. Usually, and that's actually brand new. So I could have sat for that last year to do a board. I can't tell you off the top of my head what the training looks for that now because it is only a year old. So I'm not sure exactly what people have to do to now go through the path of becoming neurocritical care trained. Subspecialized further. Not officially. So you won't get like a board certification other than the neurocritical care, but you can become even more of an expert on, say, like the ECMO machine, so the extracorporeal membranous oxygenation or that heart-lung bypass. You can go on and become additionally trained in that. I'm trying to think of the other, like for surgery, critical care is its own fellowship, and you don't subspecialize beyond that. Some people will go into burn, so burn medicine, but I don't know off the top of my head if there is like a board certification for that, or if it's just a path that you choose.
All right, does anyone else have any other questions? I guess that's it for this evening. Again, yeah, thank you for joining us, and thank you to all the students as well. They're staying after.
Yeah, absolutely.
Dr. Millender, thank you so much for having us.